as well. Thank you all for coming today. All right. Okay, we'll get started. Again, thank you for attending today. Super excited. I'm Robin Truslow from the Calvert Library, and we're super excited that Dr. Folsom Elder has been willing to answer some questions that we have heard out there about the vaccine. Dr. Folsom Elder works at the health department, and she is going to share her knowledge and expertise today, and also her background, so you'll know a little more about her. And I'm just going to turn it over to her to get started.
Wonderful. Thank you, Robin, and I appreciate everybody jumping on. The way that we're going to host this and do this today is I'll present sort of a PowerPoint type presentation. And then I really, we're hopeful that that addresses the majority of those questions that we put out in the poll. And if anything else comes up, of course, please let us know. And let me just get to share screen and we'll get started. So hopefully you're all able to see my lovely screen that says honest talk about the COVID vaccine. We do want people to understand that, we hear the concerns of the community and, nationwide about vaccination efforts. And we want to make sure that people understand where things are kind of coming from realistically here. So obviously it's today, and that's me. I wanted to make sure that you guys know a little bit about me. So I am a family doctor by training. I attended Bishop McNamara High School right up the road in Forestville. And then I went up 95 to College Park. I graduated from there in 2001. Did my medical training at the University of Maryland in Baltimore and graduated from there in 2005. And then did my 3 years of family medicine training at Jefferson in Philadelphia. And I made a U-turn and I came back down in 2008. Graduating from residency and seeing patients. And I did full-time family medicine from 2008 until last year when I came on board to serve in the public health arena. And Dr. Polsky had actually already offered me a position for things like diabetes, and smoking and cancer prevention. And then COVID hit, and obviously things got a little bit sidetracked for a little while. So I do have 4 wonderful children, wide ranges of years of age, and a wonderful active duty service person, husband. And I do want people to know that I have no financial disclosures or conflicts of interest. In fact, I'm not allowed to have those as a state employee, but personally, I have no financial disclosures to divest. So just a little bit of background, just so that we're all on the same page in case we get into some of the language here in a little bit. But COVID-19 is obviously the disease that's caused by this novel coronavirus, SARS-CoV-2. And when we talk about vaccination, inoculation, immunization, we're sort of referencing that term that is used to discuss providing an activated or dead portion of a virus or bacteria to a person so that they create their own protection against a disease. If they're faced with it in the future, they're going to have an immediate response. And that response is typically minimal and doesn't lead to negative health outcomes like death, hospitalization, or chronic illness. Hesitancy, I will use the language, just kind of a reluctance in doing something. I don't think that this is necessarily a positive or negative thing. I think people are hesitant to do certain things at all stretches of their life. So we know that that can be something that happens when it comes to vaccines. In case people are curious about what we use in terms of COVID-19 disease, isolation is the period when someone is infectious to others. So I equals I. And that's usually 10 days from the start of symptoms or the date of the test. And then quarantine would be the period of time when people who are close to COVID patients would need to stay home because they themselves may get ill and transmit to others, just in case those topics come up. Why is this important? Well, it's important because COVID has killed millions of people worldwide. There have been a little under 3.5 million deaths through the world, and there have been 592,000 deaths here in the United States, and that's through data through earlier this week. I know that people, family and friends of mine included, sometimes doubt the authenticity of death certificates. But death rates in the United States remain fairly constant from year to year, unless we have a really bad flu year or something like this, or a natural disaster. But last year, there was a 23% hike in all-cause deaths in the United States. So that means that all-cause deaths means anything and everything went up by 23%. And so we know that when that happens, during a worldwide pandemic, a large proportion, if not almost all of those cases, were from COVID. And the others would probably fall into the category of people who decided to wait on screening for cancer, heart attack treatment, stroke treatment, et cetera. And I'll just circle back to the death certificate thing. So as physicians, we are taught how to fill out death certificates. And when they are completed, there's no compensation for filling out a death certificate. So if I had a patient who was in hospice and that person passed away because of a terminal disease like cancer, and I completed that death certificate, there's no compensation for that death certificate. There's no benefit to me skewing whatever I'm putting on there. Circling back to the data, 33.2 million cases in the United States, again, as of earlier this week, 459,000 cases in Maryland with over 9,000 deaths. And then here in Calvert County, a little over 4,000 cases with 78 deaths. Nationwide, we do know that children are infected with COVID. If you ask anybody who works in the school system right now or in daycares, we know that it happens. Very rarely, we do see kids that develop this MIS-C, which is a multi-system inflammatory condition. And we know that rarely deaths can happen in children, but we know that other variants of the disease, genetic mutations, can cause increased virulence and increased rates of death in other age groups. So we do want to be mindful that that can happen here with these kiddos. In our poll, and when we look on social media or when we talk to the community, we hear a lot of reasons for non-vaccination, and some of them are as simple as, how can I get the vaccine scheduled? I only want J&J, but other ones are about vaccine ingredients, worried about long-term side effects, believing it's too rushed out or that they're going to be a guinea pig, worrying about genetic changes to our own cellular structure, trusting your immune system better than a vaccine. And we will go into this, but in many cases, your immune system does work really good, really well. But we want to make sure that people understand that with that could come other things. And so vaccine will prevent those. And then lack of trust in public health or the government, or just a general sense of distrust since all of this happened. Many of these reasons are valid concerns. So I don't think that people, I hope people leave this discussion understanding that we know that people are concerned about it. And maybe it's just one or two pieces of the puzzle that they might be missing or that they might have been misinformed about. So we're going to try to walk through all of these. And then if you have a medical provider, myself, Dr. Polsky, both practiced clinical medicine for a long time. And we feel very confident that people need to be talking with their regular medical provider about this. So please bring these questions or concerns to your nurse practitioner, your PA, your medical doctor, like an MD or a DO. Those are people who you should trust for that information. So I put on here the vaccine ingredients. I took snapshots of each of these, and these are from the company's own material that they put out. And this isn't just for COVID vaccines. Every vaccine has to have one of these statements, and they're like a 17 or 18 page document usually, and they go into great detail about aspects of the actual vaccination. So for Johnson & Johnson, you can see that we are just basically giving the information to the cell to provide that makes that spike protein. And then there are some chemicals that are in there for making sure that the molecules are in a suspension that's going to be able to be provided in vaccine format. Same thing for Moderna and Pfizer, although for these, you're really just getting the messenger RNA, and we'll go into the details about what the science behind that is. And then they contain fats and other things. Interestingly enough, I just took a snapshot of the Shingrix. When I was in clinical practice, everybody, when shingles vaccine became available, it was like I got inundated, like, can I get the shingles vaccine? And shingles is rarely, if ever, fatal. It's a very painful disease, but it is rarely, if ever, fatal. And so I just want to kind of make sure that people understand that when we're looking at vaccine ingredients, this is the shingles vaccine ingredient. It has many of the same chemicals, has many of the same things that allow us to be able to provide that vaccine in a liquid diluent formula, that we can kind of do this in. So I just want to make sure people are aware of the vaccine ingredients. The vaccine ingredients are actually some of the smallest vaccine ingredient lists that, for these vaccines. So they've been pared down to decrease things like preservatives, formaldehyde, all the ones that people get worried about in some of the other types of vaccines we have. So one of my good friends, Dr. Cardella, and she's a local provider, told me that when she talks to her patients, she talks about the basics of genetics. And we're going to take you back to high school, biology, or maybe bio 101 if you went to college. So we're talking about deoxyribonucleic acid versus ribonucleic acid. And so when you look at the two things, they are very structurally different. DNA is a double helix. It means it has two components. They have to line up, and they are comprised of these subunits here. RNA is made up of one of those strands, and it's made up of different units. 3 of the 4 are the same, but then the 4th one is different. And when you talk about DNA and RNA, I like the analogy of a zipper. We cannot make a zipper from one side. So a zipper has to combine together seamlessly. They have to line up and they have to go up. We can't use RNA to go back to DNA. So even if you took one strand of RNA and one strand of RNA, they don't together become DNA. So we'll go into the specifics of that. But this is a really great analogy for people who are trying to understand the differences between DNA and RNA. Again, going back to bio, so this is how DNA becomes RNA in our system. So we have a nucleus in our cell, and DNA gets transcribed, and then there's some RNA splicing, and it gets exported out into the cytoplasm, and then ribosomes translate mRNA into proteins, and those proteins then get expressed on the outside of our cells. You can see here on this little diagram, a single code of a genetic material. So this double strand of DNA becomes a single strand, and then it becomes transcribed into RNA. What you might miss, you might not see, is that there is no arrow back the other way. So these arrows are unidirectional. They cannot go backwards. So there is no ability for instance, an mRNA to go back into the nucleus to then affect DNA. It's just impossible. And this technology, we've known about DNA science for multiple decades. And when people submit their DNA for 23andMe, for instance, that is your DNA. Okay, so very different from your RNA. So just hopefully people are aware of the structural changes between those two. Another good analogy, Dr. Singh from Bayshore Pediatrics told me this one early on, and I thought it was a really good analogy. But when we give somebody the mRNA vaccine, we're basically giving them a blueprint for our body to create a protein that our body will then recognize if it's exposed to it. So, for instance, his example was, our blueprint of the mRNA is going to give you the spike protein, and maybe that looks like this door. And so when this door gets, your body gets exposed to this door, it's going to have an automatic response system, so that very quickly you'll get a response if you're exposed, and you will then have fewer symptoms. You will be less likely to die or be hospitalized, and you will also be less likely to transmit to people around you. And so we'll get into each of those subjects. I'm not going to go into T cell and B cells, but there is a difference between T and B cells and how they fight and do the immune response. So just be mindful that some of what the vaccines are doing is creating a B cell response, and some of it is creating a T cell response. We can't really measure a T cell response from specific blood tests or anything like that, but we can check for B cell response with antibody levels, and that's really what we know of. This is just a good graphic. I'll go on record the New York Times articles on these things, and I have references at the end, but these are really good sources for pictures and a very good visual. And so what we're hoping to do is that when we create antibodies, that if you get exposed to the virus, these antibodies will latch on, they block those spikes from attacking other cells, and then eventually these T cells will help degrade these cells that actually have the infection. And so it's a very coordinated effort. This happens anytime you see a virus or a bacteria. And so it's really important to know that this is the way that our body reacts to these things. So the J&J technology is a little bit unique. I'm going to go with this one first, just so that people understand. The DNA vaccine, and this is DNA, but it's DNA for that particular spike protein. So this is not DNA for some other organism, goat or sheep or another human even. It's DNA for that particular protein. That's the spike protein. And so they put it in an adenovirus, and this adenovirus is incapable of replicating in our system. So they take out the genetic portion of that adenovirus that allows for people to have an illness as a result of it. And that's actually how many vaccines for your dogs, for your cats, for yourself, that's how many of them are actually created. And they're housed in this non-replicative, non-infectious virus. So that's the way that we're doing it with the J&J vaccine. The DNA goes in that adenovirus vaccine. Your body takes that vaccine up, that vaccinated portion, and it takes it into your cell's nucleus. And this can't combine with your own DNA. But again, it just goes into the mRNA, and that creates that protein to make that spike protein. The mRNA research and technology is a little different because the vaccine particles actually only include mRNA. They include no virus. They include no other host. There's nothing else that goes in there. It's just the mRNA. And that mRNA gets absorbed into your cell, and it actually never crosses into your nucleus at all. It cannot go backwards into your nucleus. And so that mRNA uses a ribosome to create a spike protein, and those spike proteins then get displayed, and our body creates an antibody response, and we're good to go. Wanted to put a little history of mRNA vaccine technology in here. So in 1990, and for reference for those of us who maybe get a little bit confused about how time works, but people who were born in 1990 are now 30 years of age. So in 1990, there was the first report of use of in vitro mRNA in animals, and that was published back in 1990. In 1992, what happened was they started administering mRNA types of molecules to rats or other lab animals, and they were able to induce physiologic changes. So for instance, they put in a vasopressin type of mRNA, and vasopressin actually works on a portion of our brain. And so they were able to induce some physiologic changes this way. The main thing about mRNA technology, which is also kind of goes into why this came out so quickly, is that I'll go through the parts of this, but it's really safe. So again, there's no infectious material going into you at all. There's no potential risk for any mutations or any infection from the vaccine itself. mRNA molecules are degraded by normal cell processes anyways. So I got my vaccine back December 30th was my first one. And ultimately, that mRNA molecule was degraded very quickly by my cellular mechanisms. And it's effective. These create really highly stable proteins. So these proteins, we know that they're going to be the exact same proteins time after time after time with this mRNA vaccine. And vaccines like this can also be administered repeatedly because it's a really small piece of genetic material. So it's not a large group of DNA molecules or anything like that, really small pieces of mRNA. And it's really quickly made. So for most vaccines that require other viruses or cell cultures, they take time to ramp up production. That's not needed for mRNA technology. There's no need to use cell cultures to grow things in a lab. So it's rapid, scalable manufacturing, which is what happened here in the United States, of course. A brief primer on how vaccines are studied. So, and none of these phases were skipped in any of the trials. So just to kind of give you a heads up. So phase 1, the vaccine's given to a very small number of very typically healthy people. So these are people who may not have any medical comorbidities. And that gets a baseline sense of safety. It gets a baseline sense of how well the vaccine would work to induce an immune response. And we talked a little bit about antibodies, and the way that they sometimes measure this is by doing a blood test to see if people have antibodies to that spike protein who have not had infections. And then in phase 2, if they haven't seen any safety issues during phase 1, more people are included in this phase. So usually hundreds of people get signed up, and they widen out the demographic groups. So now they're looking at people with maybe some various health conditions, and they look in a randomized way, a randomized controlled trial, to see what kind of doses might be helpful. They also get more safety information during this period of the trials. They look more at short-term side effects that might be happening, as well as ensuring, again, that desired immune response is happening. And then phase 3 expands out to more people, so thousands of people, wide demographic groups. And this final step involves testing vaccine versus placebo, and ensuring that we have the right dose. And the dose is really important because you don't want to put, if you don't have to put extra dosing into people, you don't want to do that. So you want to find the lowest dose possible that still induces an immune response for those people that are getting the vaccine. So how was this put out so quickly? I mean, it's really, it's a once in a lifetime for me, hopefully, situation, but we had multiple countries coming together. We had both public and private sectors involved, funding, supporting this effort. And the FDA and CDC prioritized reviewing data on this. Even if they had other things that they were supposed to be doing to review, they sort of put that stuff on the back burner temporarily so that they could review the data and expedite this. The other thing that people forget is that when the illness burden for any illness is really high, you can actually move things along quicker. So if you think about it, if we don't have an illness that's very common, when you do a study, you have to do studies for longer and longer periods of time when you don't have a lot of illness in the community. When you have a really high illness burden, and think about back in last year, we were seeing so many cases per day, and we didn't really have any treatments either. And so it really only took a very small amount of time to determine if something is highly effective at preventing illness, death, hospitalization. And those are the initial goals, to look at those things. But also, now we're looking at things like transmission rates and such. So that's another reason it was put out so quickly. When you have a really high illness burden, you get that data back so much quicker. I'll put in a really quick short thing, and I don't think I shared it earlier, but mRNA vaccine technology was actually used in multiple trials for things like Ebola and Zika, and unfortunately they just didn't work as well for those diseases, although they still are doing studies for them. But for things like Ebola and Zika, the illness burden is only in a subset of our world or in our population. And even within that population, there's not a high enough illness burden to be able to collect that data so quickly. So again, really high illness burden with COVID, especially last year and going through basically about January timeframe, we were able to see that was, we know that time period was really critical in getting that data back. So one of the common things that we hear is that we feel that this has been rushed out. And again, there was an urgency, a sense of urgency. And again, I think that hopefully I've explained that urgency came because of multiple factors. And people still are very concerned that they're going to sort of be a guinea pig. And, it is a newer vaccine. The technology's been around for a long time, as I mentioned. But at this point, we have 131 million people in the United States that have been fully vaccinated. That's about 40% of our population. And, 164 million people have had at least one dose. So that's about 50% of our population. So we have a lot of people in the United States that have been fully or partially vaccinated. And we'll get into the way that things are monitored. But by now, if there really were concerns, about particular side effects, the likelihood is very high that we would hear about those things. And we'll go into some of those concerns in a minute. Interestingly enough, and I put this data in here just to sort of show that one of the things that we're fighting up against is that there's going to be genetic mutations in other parts of the country because they're not afforded the same opportunity that we've been given to be vaccinated. So only about 5% of the population worldwide is vaccinated, and that includes us, and only about 10% have been given one dose. So we do need to be mindful that while we may not want to potentially jump on board quite yet, it does allow this virus to mutate and to become either more transmissible or more virulent. So it could make us more sick, or could start affecting younger groups of people like our children. So we'd have to be kind of mindful of that. In the first month of the vaccine efforts alone, so this is late December through late January, 13 million people were vaccinated. And I just included some demographic information, but 63% were female, 40% were under 50 years of age, and 60% were non-Hispanic white Americans. So just be mindful that this vaccine has now been out, and been given to lots of people in the United States. And by July, we're going to have full data from when Pfizer first started their trials. So we would expect that by midsummer, we'll have sort of that year-long data that most people look for. I'm going to break from the scientific, stuff right now and really just talk about some basic things that we've heard feedback about. So vaccine scheduling, we know, was an initial issue. We were getting very small allotments from the state, somewhere around 200 to 500 doses in a week, which is not a lot. Once we had our pre-registration database that had about 14,000 people who wanted to be vaccinated right away. And you can imagine if we didn't have an uptick in the supply, we would not have been able to meet the demand. So thankfully the supply ramped up, and we were able to get those people vaccinated, not only here at the health department, but at pharmacies. Local healthcare providers now have the ability to provide vaccinations. Mass vac sites, even though we weren't part of that network of mass vaccination sites, some of our county residents may have been commuting to work or may have had to go outside the county, but they were able to get fully vaccinated. And we appreciate those who stuck it out, pardon the pun. And then I did want to put a little plug in. Any and all clinics are now public, and we do now have, as of probably today, it will be on our website, but we will have a J&J clinic that will be run at actually our health department, because the allotments from the state for J&J have been, notoriously smaller. So we don't get as many doses for J&J. To sort of put it in perspective, one allotment of Pfizer is a little over 1,000. And for most Moderna vaccination allotments we've been getting have been somewhere between 500 and about 700 to 900 doses when we get them in. So you should be able to go on calvertcountycovid19.com/vaccination, and you should be able to see all of the public links so that we'd be able to get you anytime that you want. If you know people who might need their second dose, maybe they were vaccinated in Florida and they've just come back and they need to get their second dose, get them signed up that way. If you have a college age student and they've gotten vaccinated while they were at Frostburg, and they're coming back and they're not planning on going back up there, you can sign them up for our vaccine clinics here. There's no restrictions about, first, second dose, that sort of thing. This is, we hear this not uncommonly in medical practice. When I was seeing patients, I hate needles. I don't want needles. People didn't want to have blood drawn. And it's a legitimate fear. There was a meta-analysis out of the Journal of Advanced Nursing in 2019, prior to COVID, and it showed about 20 to 30% of young adults, at least, exhibit this phenomenon. And it can really cause some major issues. It can cause fainting episodes, which then go on to lead them to be even more fearful of further vaccinations or blood draws. It could also just be that they have panic attack or panic type symptoms. And so there are some techniques to help with this. We do want you to speak with your medical provider to review ways to reduce anxiety around needles. And I'll just give a couple of techniques that, sometimes would be helpful. In vivo exposure therapy is less commonly used for needle phobia, but that would be where you're gradually introduced to needles of varying size, or maybe you're around it for 5 minutes and kind of go on from there. But applied tension is a really good technique, and it's a way that you can induce muscle response. And so you're sort of constricting muscles while you're getting vaccinated or while you're getting a blood work drawn. So you'll have less likelihood of, becoming lightheaded or having these side effects. So just a couple things there, and just make sure you talk with your medical provider. And if these are the things that are holding you up, I think that, many practices are now actually doing the vaccinations in their offices. And we hear that most people would prefer to get their vaccines done in their doctor's offices. So, reach out to your medical provider and say, hey, I'm thinking about this. Can I come in and talk with you? Can I do a telemedicine visit to review? And then go from there. So, probably one of the hardest arguments is that people trust their immune system better than a vaccine. And, for most illnesses, your immune system works really good. And we know that from our studies from people, at least as far back as like 8 months ago, who've had COVID, a fair number of them continue to have, antibody protection. So it does create a long-lasting response with one exposure. The price you pay for that is that you really have no idea out of the group, especially for COVID, who might become chronically ill, who might pass away as a result of that that possibility of exposure. And we've seen people in their 20s or 30s intubated in the ICU here. So it is not all people 65 and over. It's not all diabetics. It's not even all people with chronic lung disease. Many of these people have never smoked. They don't have chronic lung disease. They don't have any chronic illnesses. And so these are people that we would not have been able to predict how their body responded to the situation. Vaccines, interestingly enough, induce they induce an immune response that generally is sustained over time. So the caveat to that is that people generally need boosters for newer strains or genetic variants. People who forego vaccinations, they themselves will be required to be exposed as well to the variant. So it's not that they're getting around those variant mutations, but they will be faced with those in real time. And again, if those genetic variants become either more transmissible to other people, or if they become more virulent and cause more health issues, that's when we start seeing, a problem. We are not sure yet if COVID vaccines will need boosters. It's entirely possible. But when I think of things like my tetanus shot, I have a garden in my yard. If I stepped on something like my chicken wire or something, and I was playing in the dirt, I have a possibility of becoming sick with tetanus. And so we need to be mindful that we are a society that is hopefully open to vaccines for things like that, for tetanus, for if I got bit by a rabid animal. So just keep in mind that those are things that you would need boosters for anyways. And vaccines come with the knowledge that the person will not become severely ill. So when you get vaccinated, especially with the Pfizer and Moderna vaccinations, if you get fully vaccinated, you have like a 90 to 95% effectiveness rate. But even those people that do have breakthrough cases, those people are not dying or being hospitalized from COVID. So we just have to make sure that we understand that that's one of the real reasons why this vaccine has been recommended so widely. Another thing is that your immune system may work, but others might not. And their transmission is another thing that researchers and scientists and doctors care about. So when you're fighting COVID infection, with or without symptoms, your body may be able to fully protect you. But if you go to church, say, or, say you go to a wedding and you're sitting unmasked in close proximity to Mrs. Jones or somebody else who might have a weakened immune system, her body just might not be as effective in fighting the infection. And you've now transmitted. If you were infected after a vaccine, you have less likelihood to transmit altogether to anybody else. And we'll go through that data in a minute. So, and even if Ms. Jones did receive her vaccine, people with weakened immune systems still may not mount great responses to illnesses. This is why people, very rapidly go from UTI to kidney infection, a minor upper respiratory infection to full-blown pneumonia. So these are people that need protection from the surrounding community. And we also have to be mindful that we have a huge subset of our population, the 12 and under kids, who have zero protection. They have no ability to be vaccinated. They have no, I mean, even some of the treatment strategies are not approved for those age groups. And so we need to be understanding that, especially if we find that kids are becoming sicker from this, it is, something that we feel very strongly that if we are protecting ourselves, we're also protecting others. And even if you've received vaccination, if you should get COVID, you will have fewer viral particles in your airways to spread to others, which leads me to some reduced transmission studies. So pretty early on, there was a discussion amongst scientists that cats may be able to catch COVID. And so there was a study done on viral load after immunization. They basically came up with a COVID vaccine for cats. And they did a study where they vaccinated cats fully, and they challenged them. I actually gave them COVID through nasal swabs and things like this. And then they tried to detect COVID, and they were not able to find any viral particles in the upper airways of these animals. A very similar study in macaques, which is a type of a monkey, basically, once again, they vaccinated these monkeys. They then challenged them with actual COVID, and then they did swabs, and they were unable to find large amounts of virus replicating in the upper airways. And now we actually have some human studies. So these are studies on people who have what we call breakthrough COVID. So these are people who get COVID after they've been fully vaccinated. And what the studies have shown is that those people, even those people, they swab them and they don't have enough viral load to even be detected. And so about 40 to 60% reduction in the amount of viral particles that are present in those people who get swabbed after, they have COVID, but they've been vaccinated and they just don't have enough. And that's really where that virus is that can be spread to others. And so we know if I am fully vaccinated and I get COVID from a coworker or from being out at the store or something, if I get COVID, I'm less likely to be able to transmit that disease to my unvaccinated children, or to maybe, a family member who might not be vaccinated. I'll go on record. My parents, my sister, my husband, my 15-year-old have all been vaccinated. And so it's really important to kind of keep in mind that we don't want to transmit to other people who have weakened immune systems. These are all of the studies, and I can, there's a bunch of them, but these are studies that sort of are studying transmission rates. And so we obviously have the data in terms of reduced death, hospitalization, and long-term morbidity. But we definitely, this is a sort of a newer thing that we're really doing a lot of research in. So you can see that the majority of those research articles started back in like February when the vaccine rolled out. I can't argue with this one. I have had some issues over the past year and a half myself with sort of being able to believe or trust in certain things, political parties, even people who are not politically motivated, but who might be at positions of leadership at all along every sort of governmental spectrum. And I think that it's a real issue that probably, nationwide we need to look at, that not even related to COVID, but that there's some major issues here. But I'd like to pose this question to anybody who's on this talk. How many of you trust a medical professional with whom you seek care? Do you trust your kid's doctor? I mean, I do. Gosh, every time I go in and see them, for things. For the ER doctor that might have saved your family member. Maybe your family member had a heart attack or stroke, and that ER doc knew exactly what to do, how to treat that person. The hospital doctor who cares for your family member when they have cellulitis or pneumonia, or, they have a blood clot, or post-operatively after surgery. Or the OB doctor who delivered your grandbabies. Do you trust those people? Or like me, the family doctor who saw you every 6 months for your high blood pressure and asked about your garden or your cars. And so these are things that, we really want to drive home, that these medical professionals with whom you have a regular, constant communication and connection, those are the people you should really be getting a lot of your advice from. And I will, I did a survey earlier this week, and so I wanted to kind of just present. So 90% of Calvert Health Medical Group outpatient providers are fully vaccinated. 93% have had, first dose, and then 96% are fully vaccinated Calvert Internal Medicine Group. Keep in mind, there are some people who legitimately can't because they have an allergy to some of the components of the vaccinations. And, It's not mandated yet in healthcare settings, nursing homes, doctors' offices, but they are widely accepted by most medical providers, medical doctors, doctors of osteopathic medicine, nurse practitioners, physician assistants. And I'll go on record, I'm not naming names, but there are many people in our community who are chiropractors or social workers or therapists, who have decided and chosen to get this vaccine because they know that it protects them, their patients, and it protects their family members. I will put a plug in here for the health department. If you don't have a medical provider or you're having difficulties obtaining insurance or finding a medical provider locally, call the health department. We'd be happy to try to get you set up with insurance or find you a medical provider, as best we can. So that's what we're here for. So a couple more points, and I know we're getting close to the end, and I wanted to have a little bit of time for question and answer, but a lot of people are worried about the long-term effects of the vaccine. And I understand that, this has only been out for close to about a year. And certainly we don't really know if there's going to be anything that comes of it. But I'll be honest with you, vaccines in general, really their side effects happen within probably the first 24 to 72 hours after administration. So if you're going to see a side effect, and this goes back to any vaccine that I gave, to little 2-month-old babies or 6-month-old babies or 4-month-old babies, usually when you're going to see a side effect, it's going to be within the first 24 to 72 hours. Very rarely will side effects happen as late as a week or two out. And then once you get much past 2 weeks, vaccine side effects just don't happen. They get degraded by the body very quickly. Our body has an amazing way of getting rid of things like waste and all sorts of stuff. And so it's very rare that we would be able to see any vaccine-related illnesses happen, this far out. Even in rare cases of things like Guillain-Barré or other types of well-known side effects for other vaccines, they occur relatively quickly after vaccine, and usually they're treated with supportive care and people do okay. The other thing about things like Guillain-Barré or other types of illnesses as side effects, those things actually can happen during the illness itself as well. So, people used to say, well, I could get GBS after Guillain-Barré syndrome after my flu shot. Well, actually flu can cause Guillain-Barré. And so you need to be mindful that sometimes, the vaccine, it just can happen regardless. We do know short-term side effects, arm soreness, fever, chills, headaches. Those are very, very common for most people who get the vaccine, although all three of my family members, my mom, my dad, and my sister really didn't have very many side effects, hardly at all. One thing that's come out of having the vaccine out on the market is that we now know that for women in particular, because they have to go get their mammograms, but for women in particular, we do know that there's some lymph node swelling typically on the side where you get vaccinated. That's actually a good sign. It means that your immune system's working. But for women who might be going to get a mammogram, if they are just coming off of getting their vaccine, you certainly don't want to confound the information that you're gathering on that image. And so you might be asked by your radiology group, have you had a recent COVID vaccine? It's not because they're worried that it's going to give you something. It's just that if the doctor sees a lymph node swelling or something like this, and it's been really close to your Pfizer vaccination or your Moderna vaccine or your J&J, it could be a side effect of that vaccine rather than something real on that mammogram. All right, on to the fertility topic, which is probably the number one thing we hear in the community on social media. I have friends and family who are worried about it. So, this fertility concern came about by a German doctor and a former Pfizer employee who asked basically the European agency that functions like the FDA to delay approval of the vaccinations. And they were worried about a specific protein called syncytin-1, which is on the placenta. And so that shares some portions, some short stretches of the genetic sequence with the spike protein. And so the theoretical concern, which was not really founded in any actual scientific studies or anything, the theoretical concern by them was that could lead to our body sort of fighting the placenta. So a couple things. Our bodies see hundreds of antigens in a day, right? So anything that my skin touches, anything my eyes come in contact with, or anything that I take in my mouth, those are automatically things that my body has to process and say, is this a friend? Is this a foe? Do I have to fight it off? Do I not? The second thing is, and this probably is more for kids than adults, but kids in particular are little germ factories, even with their masks on. They're outside. They might be, my 2-year-old probably licks playground equipment and all sorts of things, but they're around a lot of different antigens and exposed to a lot of different things. And so please be mindful that our bodies are set up perfectly to be able to determine what is what. In fact, some of the autoimmune issues that we now know, plague people, type 1 diabetes, certain types of autoimmune thyroid disorders, they're actually created because of the way our body may respond to a particular virus. So again, getting the viral infection can actually create issues. COVID-related diabetes is actually one of them. So COVID itself can cause diabetes. There's a worldwide registry for people who have developed diabetes after COVID. They've never been told they have an abnormal sugar before. They get COVID and then they develop diabetes. And so we know that viruses themselves can cause autoimmune issues. But a good example of outlining, sort of this concern about the shared genetic data and the shared genetic sequence is if me and my best friend have phone numbers that are similar with 2 sequential numbers. All the other numbers are random. They're not cross other numbers, but 2 of the numbers, maybe I have a 3-1 in the number, and so does she. And somebody's trying to call her, they can't call my phone number to get to her. So the 2 are not the same. They share a stretch of the same data, but they're not the same molecule. Another similar explanation would be, wolves and dogs share a portion of their genetic sequence is shared, but they do have different genetic material that make them either wolves or dogs. And so the spike protein for COVID and syncytin 1 are completely different appearance-wise, and they only share a short segment of genetic material. I forgot. All of these organizations are on board with COVID vaccination for pregnant women, for women who are thinking of conceiving, and for lactating women. The American College of OBGYN, as well as the American Society for Reproductive Medicine, clearly recommend this vaccine for women. Shady Grove Fertility and Fertility, they recommend it. And I will put a little bit of a spin on this. I believe that most OBGYNs are probably more conservative about things that they would recommend for their pregnant women. So for instance, when I was pregnant, you can't have deli meat. You shouldn't have soft cheeses. You definitely shouldn't have alcohol. You shouldn't have certain types of medicines. So for an organization that's notoriously cautious to go on record and say, we believe in this, is a huge indicator to me that they are thinking that this is a good idea. And then just to look data wise, if we took just the women who were vaccinated in the first month, 63% of the 13 million, and then we take 40% of those women because we know that they were under 50, then about 3.25 million women were vaccinated in the first month alone with Pfizer or Moderna. J&J wasn't out at that point. So, we would have heard of fertility issues by now if a large swath of women somehow were not able to conceive within that first, 6 months after they had been vaccinated. And then that brings me to my topic of Varus and vSafe reporting mechanisms. So Varus is a reporting system for medical providers who give vaccines. And it is required by law to report to Varus specific adverse events. And I put a little link in here, but ultimately there's a list of things after each vaccination. And so they break it down by vaccine. For instance, death, it has to be reported. Significant side effects, adverse events that are listed by the vaccine manufacturer as a contraindication to further doses. So if I get my tetanus booster and I have a reaction that would keep me from being able to get further tetanus boosters, that has to be reported. Healthcare providers are strongly encouraged to report other adverse events, whether or not we think it's causative or not. Like if somebody passes out, we're strongly encouraged to, or required to probably, but maybe that's a bad example. But if something happens, we are encouraged to report any and all things to Varus. The other thing that's required is a vaccine administration error. So if somebody gets a different vaccine, or if they get, maybe a smaller dose or something like this, that needs to be reported. And vaccine manufacturers, so if you called, say you got Pfizer and you had a side effect and you called Pfizer's number and you told them I've had this side effect, Pfizer's technically required to report to Varus as well. vSafe is a really cool new system, and it came out just for COVID. It's smartphone based, and you register for it after you get your vaccine. So all you have to do is click on the link. It's a smartphone app, and they actually call you and verify how you're doing after you register. And you just have to plug in like your lot number and which type of vaccine you have and everything. But it's a really great new way of us getting direct feedback. So that brings me to J&J. So because of this, there was a pause in late April for J&J, and basically they had reviews for data and concerns, and there was a rare clot formation that was associated with low platelets. So typically with clots, platelets aren't really should be low. So they looked at the small number of cases. There were 6 nationwide out of about 6 million doses that had been administered. So literally 1 in a million chance. And these cases were all basically in women that were premenopausal. And so what we have come to find out, and still women who are premenopausal, again, the majority of those people did just fine. But since we do have ubiquitous supplies, ample supplies at this point, Dr. Polsky and I feel very strongly that if any man or any postmenopausal woman wants to get J&J, there's no reservations that we would have. But certainly in a premenopausal woman, maybe she would want to talk to her provider, or she would just want to go for Moderna or Pfizer, because there's, really, there's no risk of blood clots with those 2 vaccinations. And this pause actually affirms the networks and the safety monitoring of the vaccine. So we have to be mindful that this is actually one of those scenarios where in the trials didn't show this, but once it became widespread to lots of different people, we saw this happening, and it stopped, it paused, it said, okay, this is where we're at. These are all the cases that have been reported, and we feel like it's still a worthwhile vaccine. So very recent in the news, discussion about myocarditis has come up. And so just to kind of let people know that, ultimately myocarditis, especially with younger people, is being looked at or has been sort of communicated that might be some sort of concern. But I want to present to you that myocarditis is inflammation of the heart tissue, and usually it's in younger people. So it's caused typically by viral infections, and these are usually non-specific viral infections. So it could be enterovirus or norovirus, a bad digestive bug, or a respiratory illness like a summer cold. And sometimes, rarely, it's caused by hypersensitivity reactions to medicines. So we do know that medications can sometimes induce myocarditis as a side effect. It affects 10 to 20 cases per 100,000 people. So it affects about 1.5 million people worldwide each year. And so we're really unsure if this is a correlation or a causation. So correlation would be just, we see it at baseline at a certain level. And so we're just going to continue to see it at that baseline level amongst anybody who's getting the vaccine. Or is this really truly causative? Is this really something that's coming out that says that the vaccine is causative? And at this point, there's no indication that it's causative. So myocarditis data, there's about 75 deaths per year in athletes between 13 to 25 years of age. So it's young people. And those deaths in highly skilled athletes are usually related to some sort of cardiac issue. And you can see here that myocarditis accounts for about 6% of those. And so it's the reason for sudden cardiac death in 5 to 22% of athletes less than 35 years of age. Unfortunately, it's probably underreported because the only way to truly diagnose myocarditis is with a particular type of biopsy. And so for those who live, who aren't passing away, we don't really know fully the extent of the damage to the heart muscle, but clinically those people might have signs and symptoms of myocarditis. And you can see here that for myocarditis, there's some specific parameters for, when that somebody who has had myocarditis needs to stop specific things like heavy duty workouts or moderate intensity exercise. So that's the end of my talk. I really hope that this has been informative, and for anyone who's on the talk who has either already gotten their vaccine or who is interested in getting the vaccine, certainly I hope that you'll go forward with the plans and talk with your family and friends. If anybody is vaccine hesitant, or maybe who is not really looking to get vaccinated, I just hope that you can come back and reference this talk. And if you want to shoot me an email, I'm happy to answer any questions or answer any address any concerns. But ultimately, our goal is to try to get as many people in the population vaccinated, not only to reduce your risk of your health burden, but really to protect those people who have no possible way of being protected at this point. And so I will stop there. And I'm going to go ahead and stop sharing my screen. And Robin, I don't know if you need to come back on or.
I think I appreciate this was a lot of great detail that covered certainly the responses we saw in the survey.
Yes.
But we may have people here that didn't do the survey. So
Yes.
yeah, please put your questions in the chat or the Q&A, either one. We can see both.
Yep.
If there's something that Dr. Folsom didn't answer or concerned, this is the time for that.
Yep. And please feel free, like I said, to email. I'm, like many of us, I'm tied to my email regularly. So phones, not so much, because I could be away from my desk. Robin, I'm seeing a hand up, but I don't know what that means.
Let's see, maybe she can't do the chat.
Okay.
So are you okay if I allow her to talk?
Yeah, yeah.
Right. Eunice, go ahead. You have to unmute yourself though.
Mute myself. Okay. Hi.
Hi.
This was just awesome.
Great.
Yes. I have a question, doctor, about what is the public doing about the people who like myself that got both shots, but how about the honor system? People are still concerned about that, the honor system of masking or unmasking.
Yeah.
How long how long do we have to wait to get the real answer? Or I mean, because I carry my little certificate around, but
yeah, I mean, that's a great question. I keep it in a plastic little carry case and with me at almost all time. I mean, thankfully, us women, we have purses and things, but I don't suspect, looking ahead, that there will be any mandate to provide that. I do think that there will be places and businesses who opt to require vaccinated people or need, sort of verification of their vaccination status before they let them enter unmasked. I don't know that will be a legal mandate, but I do think that probably there will be options for businesses to do that. I do know that there are discussions at the state level in terms of health providers and healthcare settings, being able to lift mask mandates for fully vaccinated people. But I just don't know that we'll ever get there with businesses, having to look at that. I am aware that I'm pretty confident flying and travel does require that. Am I addressing maybe I'm not addressing the question, Eunice?
Yes.
Okay.
Yes.
Yeah. And it does make me feel uneasy. I'll be honest with you, even with my fully vaccinated self going into places that,
Right.
and I certainly feel like it was a little bit of a backward step for my kids, because I wholeheartedly don't feel comfortable, going into some places with them now because they just don't have that level of protection that myself and my husband have.
Right.
It's great for some people to be able to have a bit more freedom, and I'm all for that. But it does, some of us are a little bit more cautious and worried about that. So we'll see how it goes. But yeah, I hope things. We are lucky. Robin and I were talking earlier. We are very fortunate that the large majority of our 65 and over community is fully vaccinated, somewhere around 86%, I think it is. And that's great to keep those numbers down in terms of their illness burden. But certainly we really need to hopefully get for people, get more younger people. Oh, I see.
Yes.
Yes. And I see another question in the chat. I didn't realize that the chat.
Thank you.
Yes. Thank you, Eunice. Thank you for jumping on and hopefully you stay well. Robin, do you want to, or should I'll just go ahead and read this. So one of the participants is asking for proof of vaccination, a violation of HIPAA. So HIPAA is actually geared only towards health like doctor's offices, insurance companies, medical practices. So individual businesses, actually, it doesn't even apply to them. So HIPAA is not really something that it wouldn't be a violation of HIPAA if, like, say, I'll just take, for instance, if Dreamweaver decides to require vaccination proof or something like that, that would not be a violation of HIPAA. Now, legally, could they get into some, discussions and frustrations and stuff like that? It is possible, but it's not a violation of HIPAA. It would be a violation of HIPAA if I were to go out as a medical provider and say, Robin, didn't get her shot, or Robin did get her shot, or something like that. I am the medical professional. I should not be the one expanding upon that medical knowledge. Is the option to wear a mask to go in someplace that wants to see a vaccination? So yeah, I mean, ultimately, I would think that the best case scenario is that any unvaccinated person continues to mask wear. And if they're not going to vaccinate, I mean, if they either can't or will not, mask wearing is a very, very low burden thing to do. I think most of us have gotten fairly good at wearing a mask over the last year and change. So yeah, for an unvaccinated person and for a business, that might be a good sort of compromise, right? So you can come in and shop at my store. If you're unvaccinated, wear a mask. If you're fully vaccinated, you can come in without a mask. And I'm sure that individual companies and businesses may eventually go into doing that. And I don't know what the legal ramifications might be or anything like that, but I suspect that that's where we might get at some point. I was told to make a copy of my vaccination card, take a photo on my phone. Yes, great idea. And I actually used to do that with patients when I gave them an EKG. If I did an EKG on them for chest pain or for something else, I would tell them, put this in your favorites file. So yeah, and you can also probably, I would suspect that Apple, being Apple and probably Samsung, they might be coming up with that even as part of their like health component of their smartphones. How you can put like all your doctor information in there. I mean, that would be helpful too, so that would sync up. And I will say that when our contact tracers are talking with people who might be a contact to a case, we are required by law to verify immunization status through a database, through a statewide database. So we are verifying, like if I came in contact with somebody here who had COVID and I said, well, I'm fully vaccinated, I'm on the phone with the contact tracers, they would look up my information in the system and make sure that I did have both of my vaccines. So.
Dr. Folsom, there's a question is there any correlation related with strokes after the vaccine or relates to strokes after infection of COVID? There's more parts to the question, but I'll start with those.
Yes. Yeah. So absolutely, COVID infection can create blood clotting issues. And so that can happen in the heart. It can happen in the brain. Stroke is just a problem with the blood flow in the brain. It can happen with blood flow to the lungs. The kidneys are another area that we see not uncommonly. The kidneys can be dinged, so people can need dialysis after they've recovered from COVID. So yes, that can. There has been no study or interest in, or there's been no common denominator of strokes happening after COVID vaccination. But yes, certainly with COVID. And just to kind of circle back, I know this might not be the person's question, but COVID can actually cause short-term infertility issues. There's actually some studies that show that COVID disease can actually slow down sperm motility. It can decrease sperm counts temporarily after illness. And so we also want to be mindful that there's ongoing studies for all sorts of those sorts of things. And again, that doesn't affect somebody's health in terms of like death or hospitalization, but there are going to be some long-term consequences of COVID infection that we're getting as well. Robin, I'll let you finish.
The other part of that question was, is there any chance of microscopic blood clots post-vaccine and infection that's not getting recorded since a causal relationship is hard to prove?
Right. So for blood clots, certainly any blood clots that would take you to the emergency room or to a healthcare provider, those go on your record. I mean, those are going to be filed. And if you're within a specific window after vaccination, they're going to be reported to VAERS. Also, additionally, if you get the vaccine and then you get a blood clot, you're going to have to report that, or you could report that to be safe. Certainly for COVID illness, we know that microscopic blood clots are possible that might not get to the point where they've completely blocked off an artery into the lungs or into the kidneys. But yes, you can definitely have microscopic thrombi that are happening after COVID-19 disease. Yeah, I mean, I would say that if you are worried or reluctant about that sort of thing, again, sort of circle back with your provider. Also people have individual risks for clotting themselves. So for instance, a pregnant woman, high risk of clotting, a postpartum woman, high risk of clotting, people with certain types of blood factor deficiencies or things like that, high risk of clotting. So then you're going to want to talk to your provider about which one you want to get, which type of vaccine is best for you. So that's probably the best source of information for that.
And then I think we have a final question that says, people I've spoken with are curious about the long-term effect of the vaccine. How do we know what happens 10 years from now? She actually quoted an NCBI, NLM, NIH.gov site.
Yes. So, I mean, if you're talking about whether or not we're going to need boosters, I can say with probably relative certainty at some point there may have to be a booster, or maybe there'll be a genetic strain that we'll need to know to vaccinate against. If you're talking about like long-term data in terms of like reactions to vaccines generally don't happen, months, even weeks out from the vaccine administration. And so although that information is kept, it's very unlikely that you would say, I would get my vaccine December 30th and, I'll have something happen this December that was attributed to the vaccine that was administered back then. So certainly I think long-term, a lot more data needs to be created for whether or not we're going to need boosters or whether or not we're going to need these vaccines on a regular basis. Is it going to be every 2 years, 5 years, 10 years? We do know that they're still continuing for the people that were, initially in the trials in June. They are still collecting their antibody data ongoing to verify that they still have protective immunity. And they're also doing those studies in people who actually had COVID as well. And I'll go on record too, for young children, there are studies ongoing for young children. I signed my kids up. Unfortunately, the trials were already full. But there are ongoing trials currently enrolling for children. So if anybody's interested, I know Moderna and Pfizer at least have been doing that. So. Okay.
And then there's a question about if you're on blood thinner, does that make any difference in relation to getting the vaccine?
No, you absolutely can still get the vaccine. It's important for our vaccine administrators to know about any blood thinners because they will need to apply pressure for a longer period of time. And it does increase the risk that you may get bruising or bleeding at the site of the vaccination, but there's no contraindication in terms of blood thinner, being on a blood thinner or having a clotting disorder, getting the vaccine, especially the Pfizer and the Moderna.
I'll circle back a little. The article that was cited about long-term effects for vaccines is the 2002 article entitled Neurological Adverse Events Associated with Vaccination. It talks about autism, I think around the theory of autism and Guillain-Barré and other things that may be related to vaccinations. Do you know more about that?
I don't. So, and we can follow up on that. And maybe, if people that are attending, want to have a discussion more at some point, or if anybody has, again, questions, they can send my email, and maybe Robin, if you don't mind sending me that would be great. And I appreciate everybody coming today. It's really important that we, help. We know that there's a lot of misinformation and disinformation, and not maliciously so. I think people really truly feel like they're getting good, reputable information from social media or from specific people. But we really need people to be on board with going and talking with their healthcare provider and looking at the actual, science behind this, especially things like changing DNA and those sorts of things. And it physically can't happen. So yes, I can. One of the participants asked me for the email, and I don't know if you can do that for all of them, Robin, or I probably can send it to all panelists and attendees. I think I can do that. Does that go to everybody? I think that should go to everybody. Yes. Okay, great. So yeah, if you have any questions, again, I'm always available by email. And if there is something that I need to call you about, I'll call you about it. But my desk is kind of, I'm hit or miss here. So
I bet you're busy.
Yeah. So thank you very much for the opportunity, Robin. And we hope that everybody gets a little something out of this. today.
I think it was a lot of great information and really appreciate your time. I know you're super busy, so thank you so much.
Thank you so much. I hope everybody has a good day and a happy Memorial